doing this?
This one's exciting though. This one's really
this is
exciting. Very new. Just coming out. It's the Minuteman Procedure. Chad's one of the lead guys on this. Doug's one of the lead guys on this. Very impressive stuff by Spinal Simplicity. So Spinal Simplicity.
Yeah. So, let me introduce everybody. Okay.
Yeah.
Once again, we have some great people here. You've met Doug once, I think, so far. Doug is an amazing person involved in this. This is Dr. Costa. Dr. Costa comes out of Houston. He's going to be teaching us how to do the actual procedure himself. He's an expert at figuring out what patients need this. We talked about earlier, it's great to have a tool, but you got to have a tool to have somebody use it on. And he's great at that. We're going to have him show that today. He's one of our young, exciting physicians in our area. Amy Barnhouse is the person that organizes all the physician trainings and has been training people. I don't know how many doctors she's already trained. I've watched her put one of these things in, and I don't know any doctor that can do any faster. Maybe Todd Mosley, the CEO, is a little faster, but Amy's amazing, and so we're so thankful that she came out today from Kansas City. And so having her here, I wanted you guys to put a face to the name. These are the kind of people you're going to see when you start saying, this is honestly speaking, the thing that as you're watching today, you're going to go, this is something I need to do. And the reason that is because there's these two different kind of places where you'll find physicians in pain. You'll find some that want to just do injections, 60 of them a week, and that's great for them. And then you find the elite, and this is for the elite. This is for the people that want to really help their patients in a lot of different ways. And Amy's going to help you do that through setting up different labs in different cities. We're always doing those together, and we're super excited that you came into town. So this is Amy Barnhouse. Neil Doherty. This is the man who doesn't need any introduction, one of my very best friends. And Neil is from Fort Worth also, but Neil is the VP of Spinal Simplicity. And one of the great things about working with Neil is that he is the master of education. And so one of the things that we've been able to do is find a lot of people like these guys in this room and get them trained. But everybody in the whole space of pain knows Neil Doherty. The day that he switched over to Spinal Simplicity, everybody said, well, that's something I better look into. And what Neil does, he's a very, very introspective guy. He's always thinking about being better. And even when I get on the plane with him and I'm going to sleep, he's drawing on a legal pad what I need to learn from what our meeting was that day. So I'm thankful that Neil's here, but I just want you guys to know that the day that he switched over to Spinal Simplicity is the day that people took notice of, we got to get involved. The Amy's of the world, the Todd's of the world that already started really getting the ground ready and right for this, but Neil is here to help us promote that. Come here, Miss Megan. Megan is our new rep for our area. I'll call her superstar now because I have another Megan in my practice, and it got a little confusing having Megan. So her name is now Superstar, but she's local with us now. She's in the Dallas-Fort Worth area, and so as you can tell, we're growing like leaps and bounds, and it's super exciting that you joined us today. I appreciate you being here.
Thanks.
And then Brandon in Fort Worth needs no introduction. Brandon has run this OR more than I have. This guy could do surgery in this OR all day long. He was a tech here for like 10 plus years. And his last company, he won every award there is to win. This guy knows how to sell. And luckily he's the guy that's over Texas for our whole territory. So we're very blessed to have this team, and I'm super excited. I didn't introduce Doug, other than the fact that Doug is also the guy that introduced me to this product again. So thank Doug for what he's done.
I saw this, it was two NASAs ago,
Yeah.
back when we used to be able to go to meetings.
What was that?
Yeah, distant memory.
Yeah.
So I walked by, I saw the poster with the Minuteman on, like, that's it. Right?
I want that.
I mean, it was immediate like this, so that's exactly what we kind of been looking at European devices that are similar but not quite right.
Yep.
And that's really how I got exposed to it, just by happenstance, literally drive by.
And I think that every pain doctor has to really decide what their practice is going to be composed of and the things that are going to drive them. I think this is the thing that is going to be the most significant part of my career. I'm retiring next year, although some of you may think I should, but I really think that this has, what it's done for us as pain doctors is it's given us a real bite into the spine world. And the spine surgeons are saying, okay, these guys do know what they're doing. And we do need to give them, Steve Hochschild is one of the Texas Back Institute legends from Texas. And he told us one day, he said, don't worry about politics, leave that to Washington. And I won't get into politics, right? But he said, leave that to Washington. You do what's right for your patient. And we talked about this last night, Dr. Kosla. And so what we want to do is give a couple of slides, and then I'm going to let Dr. Kosla tell you how he finds these patients, because they're everywhere, right, bud?
Yep, absolutely.
So let me show you without further ado. So when you look at the IFU, you got to have introductions for use or indications for use for everything we do. And these are pretty broad. Who isn't going to have degenerative disc disease after age 65, right? So DDD is one of them we look for. Spondylolisthesis. We talked about how now we're looking at in plates for motive changes, how we're looking at spinous processes because we need to have those for procedures. Also start looking about how many people have a slip forward of their bones. And that instability is a big contributor to their pain, right? And the tumor. This little device is indicated for use from T1 to S1. Have you done anything higher than lumbar? If Doug hasn't done anything higher than lumbar, nobody else has either. Mr. C12 kyphoplasty over here. So he did it. He really did. He did. Yeah, he did. Okay, now that we've all taken that in for a moment. But the fact is, this procedure is going to be changing a lot of patients' lives. This little device is what it looks like. The brainchild behind this is Todd Mosley. I'm thankful for a CEO like him. He's an awesome guy. Tell us, how do we find these patients, Dr. Kosla?
So I kind of break it down into three broad categories. We've got a nice acronym that we implement into our practices. It's just as easy as DIG. You're looking for those patients that have the degenerative disc disease, and they're everywhere. And I'm fortunate that we've had an opportunity to talk about several other therapies that you can implement for that. But the next category is when it's unstable, right? Making sure to get that flexion extension imaging. And we find a lot of patients that have 3, 4, 5 millimeters of slippage. And they're the ones that are telling you, I'm going to bend forward and I feel a pop, or I'm stuck and I can't get back up. Or even something that, so yeah, we're talking about these two, but then of course, what are their goals after they've come to visit us, right? Is it their attempt to get back out there and competitively downhill ski? I have a 76-year-old competitive downhill skier that came to our practice with instability, and she was like, I'm getting back out there. What can you do for me? So she was the ideal candidate for this procedure. And then just at the end of the day, making sure that we've been able to get them their functionality back, right? They may present with just lower back pain or the sciatica, it's going down their legs. What I really love about this procedure, as soon as you talk to them in PACU, leg pain is gone.
And that's because you put a space occupier and you've used it at the same time.
So we've indirectly decompressed the space and stabilized it. And they just do fantastic.
Did you guys ever think we'd be doing interlaminar fusions? Oh, you probably did, but I didn't. So
I was thinking, I gotta tell you, so the start of the coronavirus, the pandemic, when they wouldn't allow family members back, I had this guy that I did this case on, leg pain was a big thing. So he came in, lots of leg pain, couldn't really walk very well. He's a little bit slightly demented, and no family member back, and no family member after they took him to his room. And they called me, Dr. Beal, you know, Mr. Wilson, he's out, he's outside the hospital. And he's like, he's trying to find his family, hit the exit door, and he was motoring around the hospital. I got him, he was halfway around the other side. I said, what should we do? I said, well, put him in a wheelchair and bring him back in. Tell him, glad he's doing
obviously you're doing better pretty quickly. We talked about the importance of using our social media, and Dr. Kosla is due to our same social media team, Moxie. But one of the things we're doing is we're trying to give more and more patient testimonials so that nobody can refute the results we're getting, right? Because we can tell people anecdotally, this works for me, this works for whatever. But if our patients are going on and saying, I want to share with the world my improvement, I want somebody else to get this same function in their life, that's priceless, right? So there's a couple other slides we can show if you want to go through those, Dr. Kosla. Positioning.
Positioning. There's two different ways. You can have patient lateral approach, or what we typically use to is the prone position. I think that's probably our best way to describe this, especially as most pain guys are doing their procedures in the prone position. We're used to the imaging, we're used to the positioning. So I think that's how we should approach it today. And for that positioning, in order to kind of reverse that lordosis, I just use something as simple as a gel roll, maybe even a rolled up blanket.
So positioning of the patient. This is, I tell people, you got to start thinking like a surgeon. In other words, you're not just showing up and starting. You're going to get in there, you're going to flex, you're going to extend, you're going to think ahead of time with your flex extension films, what's going to be the best to get the most anatomic reduction so that then you confuse, right?
So, you know, if they're grade 1, grade 2 spondy, you want to make sure you're taking that AP lateral while they're still awake, they're participating with you, adjust the bolsters accordingly. If you can reverse that slippage, you're going to get even much better results by doing so. So in that prone position, we're a lateral approach. The incision that we're going to be making, not very big, about an inch, inch and a half tops. Just depends on patient size. So on that point, right, we have a lot of spine surgeons that say, well, this patient's too big, we can't offer surgery.
They don't want to do anything
Right?
for them.
It's not safe, or they have other comorbidities. So this is a lights out procedure for those patients because, 35, 40 minutes and they're back to getting their life back. So yeah, minimally invasive procedure, lateral approach, 1.5 inch incision. I think we're ready to skip
Let's go,
past these
Yeah,
slides.
let's skip. So let me
Let's
just say
get
this.
into
Okay,
it.
here's what I heard about this that have made me, and I'm not one to slow down or not go forward, but I heard it takes too long. It's too dangerous, right?
Okay.
And pain doctors can't do this.
Right. And
So
blood
how would
loss.
you-
Blood loss.
Yeah.
Blood loss is the
Lots
other
of blood
one,
loss.
right?
So how do you refute all that?
Right. So the proof is in the pudding, right? The blood loss is very minimal. I've had several other physicians ask, like, "Hey, this is going to be a very bloody procedure? It's not safe." Well, in the lateral approach, we're completely behind the spinal cord.
Right.
It's just that first guide wire pin, which we're going to get into. Once we have that thing set up, the rest is just follows through like butter, and it's extremely safe.
Good.
Extremely safe.
Good. So we'll probably have to use scissors to make your initial incision.
Okay.
We don't have a scalpel, but would you like to start?
Yeah, I think let's go ahead and get started. We'll walk.
Yeah, as he's doing that, this picture here demonstrates what this is going to look like in the lateral. You can see that the target wire is going to be going in between the spinous processes, both on the lateral and AP. Some of you that are going to be doing this procedure, you may prefer to have your patient on the, in a vertical stance. I like it like this because then it looks like it's really easy to see where you're headed. You're going to be doing, we don't have a marker pin either, so just kind of mark.
Let's take a spinal needle so we can get the
Yep.
AP view
Yep,
as well.
we'll get a spinal needle from that box right there. This is what it's going to look like when we start doing our sequential dilation. He's going to do this where he's going to start with these 4 small dilators, and he's going to take those as close to the spinous process as he can. And then he's going to take the soft tissue rasp through, and then we have a sizing tap, and we'll leave it there for a second. That's
Okay.
this guy right here.
Awesome. Well, let's go ahead and get into it.
Yeah.
Let's say that our patient was dealing with a 3-4 problem, which I just did this past week. And so we'll start with our AP view, please. And just
How do you like the picture? This person has amazing anatomy, don't they?
I think this is a great spot.
When was the last time you saw that much space between the spinous processes, right?
So your finer needle is really just going to give us our target as to where our initial pin is going.
Yep.
You can place it to the superiormost aspect of that spinous process as you gain familiarity with the case. Really, where is that first initial wire going to be driving? And it's kind of just right in between those SPs. If I could take a shot there, please. And again. And so we're right somewhere in here. Okay.
You can also cheat and look if you want to.
Yeah, right.
This is an open book test.
Take a picture, please.
There you go.
And those of you who are a little bit hesitant to do a lateral approach, what Dr. Costa just said is solid gold. He's telling you you're going to put a needle in, enter to posterior, or posterior to anterior, and then you're going to come in from the side. You're just going to kiss the needles.
Aim right at the needle. Yep.
Oh, do we have a 5-inch needle also?
Need that.
Maybe a 7-inch would be better, but I think a 5 would get pretty fun.
Just numb the track,
If
right?
you want to, yeah.
Yeah, we'll just go straight. Yeah.
We don't need to numb the bilateral.
No, I think it's important that the patient doesn't feel this. Don't feel all sensitive.
But yeah, that's one thing you brought up to me when I first asked about the procedure.
Yeah.
I mean, you just numb that whole track all the way
Yep,
through,
yep.
good amount of marcaine, lidocaine mixtures
Yep.
that you guys use. and-
Yeah, you don't need to get
As
too
much
out of
local as
control.
possible. And then
Perfect.
what I'll do is when we're loading the implant, I'll actually anesthetize the medial branches so that when they're hit pachy, we're good to
Good to
go.
go. Awesome.
Okay, so I think that's ideal positioning for our guide pin, our guide spinal needle, because that's where you want the initial pin to be coursing through. The rest of the implant kind of surrounds that, so we can use that as a good marker. All right, so we're going to be cutting our model, huh?
Yeah, it's
Not
okay.
gonna- Not
No,
gonna
have
upset
at it.
anybody here?
No.
That's the point.
All right.
That's why this is last. We're gonna have some fun.
Shot. And again.
So you're just aiming right for that needle point, right?
Yep.
Right.
Shot. We have a marker. We're going to mark this guy too?
Just go for
Just
it.
do it. Okay.
Yeah.
Shot.
We're good docs. We're not the best scrub techs. You notice that?
Yeah, we need.
I feel like every time we need something, we have to go look for it. Do you feel that way?
Yeah, we need to have the scrub tech with us.
We planned this thing for months and we can't remember when to bring it. Something in the middle of the night.
Scalpel. Right?
So the rate limiting step on your incision is really going to be our last dilator. I find that about 1.2, 1.5 inch incision decreases the amount of skin tension of that dilator,
Yeah.
leading to less post-procedural trauma. I wonder if I can do it. Look, I'll do it with my hand. That's cool.
One thing you'll notice, if you can see it on the camera, is that he's coming in on the lateral, very horizontal. So he knows where his needle is, he knows where he's going, he's gonna stay posterior to that.
We're just going to keep advancing towards that pin.
How would you
Got
say
good-
it feels as far as you feel the tissue resistance?
It's very good resistance. I think maybe a little more than the live version. The live version, it slips very easily by comparison. So we probably want to be a little bit more superior in that interspinous distance, probably right
That's
around
pretty
there.
perfect.
Let's go ahead and go to AP and just kind of get a three-dimensional image in your mind of
Again,
what we're targeting.
look at how nice this plane is with the floor. Your reps are gonna be looking at that. If you're like angling like this, you're probably going too interior. Looks perfect.
So that's our target zone, right? We're going to come in, remove that.
So to review a little anatomy, there's nothing back there. There's multifidus and erector spine, right?
So to those that,
Multifidus longissimus, iliocostalis,
I love spaghetti.
and Excelsius. It sounds like a Catholic incantation.
Yeah.
You probably had a dirtier acronym than that. I love spaghetti works, okay?
So, but there's nothing back there. And if you're, I want you, next time we go to the lateral, look at the angle it would take to hit the canal. So this is very horizontal. It'd take a very skewed angle.
yep.
Once
So
again,
if
like
if you hit anything important, you just
Yeah.
need to drop the instruments back away from the table, never to return.
Yeah, I think, take the images, take your time. You're not going to screw it up. You're not going to screw it up if you try to go too quickly.
And the dilators here have markings on them. So you're actually not having to, much like with KIFO, you're taking multiple images throughout your procedure, making sure you're on trajectory. Our first pin has set us up for success on this whole thing. Shut there. And we'll just follow it from there on out. But yeah, as Dr. Beal was saying, that we're behind everything, no real risk.
And you can take
Elbow
as many
grease.
pictures as you want to. Yeah, not a frozen cadaver though. You can take pictures if you want to, but you'll see that these dilators stacked next to each other. So you might go just a tad further.
And also a comment on the blood loss. This is all dilation. So there's no cutting other than the skin. There's no incision. So the blood loss is very minimal.
Oh, for
Do
this.
you want to try it? You see that way?
Usually, yeah. What helps you sign?
It does. Yeah, we're pushing up against silicone, so it's going to not be as forgiving as tissue would.
You're getting it. This is your workout.
Yep. You can actually
That's why we had the new kid. No, I'm just kidding.
you can actually give up your gym membership.
Exactly.
Take up this procedure.
He may be the new
2
kid,
weeks
but
a
he's
week,
killing
yeah.
these things. He's doing tons of them. Got a little extension wire here. Why would you need to add that?
All right, so as we advance through the procedure, we're going to start adding longer and longer dilators. You're going to lose that initial pin otherwise. So it's probably a good point at this point to add that extension.
And this is real time, this is how fast this procedure goes. It's not like we're rushing through it or anything. What'd you say, Chad? Most of them 15, 20 minutes?
See where that is. Image, please. Shot. That's a little aggressive. Yeah, maybe 15 or 20 minutes. That's good.
I've already pushed across.
Oh, I do. Okay.
Shot.
Yeah, that's what I
That
was
looks,
thinking.
that looks good.
Yeah, pushed it across. He looked at the same image.
I told you, listen to your reps, right? I was listening.
Cooks in the
When
kitchen.
Brandon tells me to jump, I ask how high.
So what are we doing here?
All right, so this is our little rasp trying to create a little bit of a channel for the tap, which is going to be our sizing guide. It just depends on how much tissue is in your way. I personally I'm not using this part of the procedure. I'm jumping straight
It's
to
okay.
the tap.
Full disclosure.
Yep, there's a interspinous rasp, there's a facet rasp,
Good, right. This-
but usually I skip all the rasps, go straight to
Yeah, go straight to
the
the
tap.
But in honor of Ryan Doherty, who's not here, he likes his doctors with a bone rasp.
Yeah.
So just bone rasp everybody. You listening, Ryan? I know you are. That's what this looks like. This is what life is all about. Getting to use these things. I've done it on this cadaver. You can feel the grinding on it. It's awesome.
So this
All
is
right.
your
So,
sizing.
so here's
now,
where we're
right?
actually sizing. And the cool thing with this is you can actually feel where your stopping point is.
Yep.
So we're just gently applying a little bit forward pressure, creating that channel. And we've got some laser lines on the side of the tool. So when we take that picture shot there, we can actually
Pull this out.
shot.
Yep.
That's our
Nice.
sizing guide. So each of those little silhouettes, the hole that's there, shot, is going to give you the size that we're working on. And in this case, picture again, 8, 10, 12. So we're about a 12 with this one. So right now on the back table, we're going to start loading shot that 12 size implant.
Brandon always wears a tie to the OR.
Got the funny suit over it.
That's right.
And you don't need to take the lateral at all as you go through, right?
No,
And you know where you are on your feet.
Follow your guide wire.
Yep.
That's it.
Yep.
That's it.
Yep. Once you get the guide wire set, you're all good.
And at this point, while they're loading the implant, I'll go ahead and do facet blocks just for PACU. Just for PACU, like medial branch blocks,
Yep.
3 cc's at each level.
just because you're just sending the set.
Yeah. Well, that and I had one patient that had a little bit of back spasm, but otherwise, fantastic. Fantastic. All
Okay.
right, so we're loaded, huh?
Doctor, you're ready.
Show them the lightsaber.
My son over here across the room had fun with this and made it look like Luke Skywalker in one of my pictures. So I'm going to get him back for that. But this thing looks like a lightsaber to some people.
Some people say it looks
It's a
like
lifesaver, not a
There
lightsaber.
you go.
Let's get that
I see what-
clarification.
I see what you're-
You guys can have that, but I'm going to charge you every time you got it down, okay?
I agree.
Trademark.
I want royalties. You heard it here. Royalties for Dr. Stevens. Connor, your college just got paid for.
So how much further you push that?
So as you're rotating it, you just want to make sure that you're getting the wings past the SPs. Now we're at a good spot that as we try to, as we advance to the next part of the procedure where we're deploying those wings, it's not going to hit the spinous processes. All right, so we're going to flip the switch. Laser lines, yeah, I want to make sure the orientation is craniocaudal.
What Doug was just pointing out, you would figure out in a second when you start opening up, if you can't see your distal end plate, you would know that you just need to turn your orientation a little bit. That looks some money.
Okay, so then we start tightening up. And I like that you mentioned, this is real time. The procedure can be done in 20 minutes.
Yeah.
I actually had a neurosurgeon in the other room come in and say, "What are you doing?" Was enthralled by how quickly this was done. And
Yeah.
he's going to be integrating it into his
Yeah.
practice now too.
Did you ask him if he wants to get to know his wife and his kids again because he got home half a day earlier?
Yeah.
He starts doing it.
All right. So as we keep coming down, in a second, we're going to take another lateral image just to make sure that we've got
Yeah.
the implant and the orientation we
This
like.
is called the Todd in my practice. I want you guys to call this
The
because
Todd.
Todd is the CEO of this company. He thinks of everything. There is a device for anything you might need.
You're clear. You're clear. Yep. Maybe a little bit more towards me. So Kaz, yep, now you're gonna get to see your lateral view and the safety of no neural foramen, no vasculature. I like standing.
Perfect.
So we've got the wings of the implant, ideally where we want them. If you can, just give me maybe a 5 degrees up this way. It might produce a little bit better view for those that are checking it out. And you can see here, we've got it lined up nicely. We can come back up to the AP. I'm going to continue closing this thing down.
Perfect.
And it's just, you get a few squeaks there. That's it. Okay. Well, we're ready to disengage.
Yep.
I should have had you see one do one. I should have had you do this. So
Yeah.
yes, counterclockwise rotation.
That's it.
And shake it a little bit and pull it out.
From here, just kind of.
From here.
Maybe rotate this. There you go. There you go.
That's it.
Just comes out with that.
Get a final AP and final lateral image and they look amazing.
Boom.
20 minutes.
Yeah. That's really
awesome.
good. Yeah. So
It doesn't look like the top portion, the superior portion, I suppose, on the right side.
It might not be all of it.
Yeah, that's just.
It's in the lamina.
it
It's in the
is,
lamp.
it is.
Because you get that actual feel.
Look at
as
how
you're talking
interior
about
he
it.
is in that
Yeah.
space. You can't do any better than that. That's
And you
amazing.
put some DBM in there
Yes.
Yeah,
when they're
so-
loading it, right?
Good call.
Yep.
So the window,
Look at that little window right there.
looks like this. You can see through it, and you
Oh,
put
yeah, one there. Sorry.
DBM, whatever bone graft, they use a combination of synthetic biologic, mix it with bone marrow, whatever bone graft flavor of choice you want to put in here. And it says a fusion spacer, not a spinosa spacer, a fusion spacer.
And so over, what, 4-6 months, you'll have good fusion
Yes,
with the
exactly.
bone matrix. But let's talk about recovery for patients, right?
So the coding, 22612-22840.
Yep. Recovery.
Mhm.
As mentioned, in PACU, leg pain's gone right away. I tell my patients, just take it easy for 2 weeks.
Do you brace them?
I don't brace them.
I don't brace
Yeah,
them.
I don't brace them.
No.
It was Thanksgiving Day, 2:12 p.m. I went to go pick up some emergency stash that we needed for the meal. And the patient that I just implanted 2 days ago was running past me because he wanted to get the last pie.
Yeah.
But so even though they're feeling right, we just tell them kind of take it easy.
So that goes back to the G. That would be the goals. His goal was to get the pie first.
Get the pie.
Okay, okay.
One of the other things I wanted, if you were wondering what this image is, that's a spinous process augmentation. So that's cement in the spinous processes. And this was developed from any interspinous decompression spacer. This is my case. I stole that idea from Luigi Manfredi, Italian practitioner who practices in Sicily. Wrote a paper, 688 patients, 256 patients without spinous process augmentation, the rest with. Symptom recurrence without spinous process augmentation, 11.3% with, less than 1%. So that's why I do it. All this is just 1 to 2 cc's of bone cement directly into the spinous process.
Huge.
Yeah, so I mean, I think that this is a great way to end this
Yeah.
combine. Really and truly, this is a product that is going to be a huge part of pain physicians in the future. It's going to be really, I think, what puts us on the map with a lot of different surgeons' respect. But we need to be honest. We still need our surgeons to be there for different things. But if there are complications or other things, we do. But in reality, this gives us a lot of ability to treat a lot of patients that were on opiates that they had sent to us that they didn't want to operate on as well. You talked about a lot of those patients that are too sick, too big, too old, whatever.
Right.
And
A lot of patients don't want to go through that major
that's
procedure.
where I was going with this.
Yeah.
A lot of our patients, when you start talking to them about their options, even when they're younger, they just think this might be better for their livelihood.
You briefly touched on an LSO brace for 12 weeks, maybe.
Yeah,
Right.
after a fusion, yeah.
After fusion.
Yeah.
So we don't do that with this.
No.
They're back in the game 2 weeks, I'd say.
Yeah, that's awesome. So, yeah, I mean, like I said, fitting way to end this combine. So, Anthony and I are very touched that all you guys made the trip to come here. It was a lot of days and planning, weeks and months and planning, but I think you can see what we're trying to do here. And I think you guys are all part of our future here. What we want to do is we want to create a group of people that all are about good patient outcomes, all about being the best they can be in their respective communities, all about trying to do what's right for the patients, not just what they might be able to do, but what is right for the patients, how are we going to get our patients back to functionality. That's what we're all about. And we want to show the newest things that we can. And coming to Fort Worth was really an honor. And I mean, I know you felt the same when we were in Fort Lauderdale. We were going to go to my office. We figured we'd outgrow that in about 5 days. And so I think the final total, we had well over 300 people on to
Well
the
over
Zoom.
300, yep.
And then we had, of course, all the Immertech people. And I think what this really illustrated for us, that the Immertech goggles went really fast.
Really fast.
So we're going to have another one. We're going to set a date.
End of April.
End of April.
We don't know the exact date yet. The same way you found out about this one, you'll be finding out about that one. Instagram, LinkedIn, from these guys, word of mouth. This is what we're doing. We're going to bring in specialists. They're going to show us how to do this. We're going to talk about it. It's not just someone sitting there, on a podium for 50 minutes, and you're probably on your phone half the time because you fall asleep and we all have ADD, right? This is fun. You get to see exactly how to do this. These aren't scary procedures. You just need to see them.
Yep.
I think keep looking out for them. April, probably July. We're going to try to do one every quarter
Yep.
with new companies, maybe some of the same companies too,
Yeah.
to get it out there.
Remember,
Very
we're talking.
MedCraze is
It's something that
where you'll
you
find
need
out
to
about these
start thinking
procedures, too.
about it when you're a patient and you don't know if what the doctor told you is legitimate, or if you're a doctor and you want to learn more about something, go to MedPraise. It's a website you can all find, medpraise.com.
Yep.
And they've helped us sponsor this event. And I think that it's funny how many people want to get to be a part of this event,
Yeah.
but what we really want is we want people that are in it for the right reason. They have a passion for patients' care,
Mhm.
they have a passion for medicine, right? It's a gift to be able to do what we do, and we don't take that lightly. We're thankful for our friends, we're thankful for our reps, we thank, of course, having Moxie come on in. Christy's kind of camera shy.
Ryan.
Ryan, yeah, you need to get in front of here
There's
too.
some questions on there.
Oh, there's some questions?
The question is who's Ryan?
Who's Ryan?
Yeah.
Who's Ryan been?
This is Christy with Moxie, and honestly
There's
speaking,
Ryan. There you go.
for those of you who think that I'm extremely creative in my posts and my videos, she calls me in the morning and says, I need a post today. I want it to look like this. I want you to be doing this, and don't do that. And I'm like, I'll try to do that. And then she puts it on. And so Christy makes us look good. We're thankful for
She's the
that.
engine that runs this train.
Yep. Ryan's going to be putting out a lot of good.
Ryan ran the Zoom, he did all the overlay, all the AV, we had the Emertech guys doing their Emertech thing.
Yeah.
Do we want to answer some questions on this one?
Yeah, let's answer some questions. Let's do it.
Go ahead.
So what's the clinical data doing Minuteman versus LOIF?
Versus LOIM.
LLIF.
A lateral
Lateral-
open, LOIM.
There is
lateral
no
open internal
data
fixation.
on that. So the extreme lateral, X lift, D
Okay,
lift,
okay.
O lift,
Not yet.
whatever lift, there is no data comparison. The data that we have is comparing open decompression versus the Minuteman, the same back pain relief, which was profound, but statistically significantly better leg pain relief with Minuteman. But there's no extreme lateral approach comparison with Minuteman yet. Keep in mind, hasn't been around very long.
Yeah, that's right.
Ryan Doggery says, thanks for the shout out.
Tell,
It's a bunch of emojis.
yeah. Tell him that we'll get some more bone rasp for him, and you got to have a bone rasp.
Is this done under MAC or general?
So you can do it under
Yeah.
prone MAC with propofol. I saw cases
That's
in
how it-
Minneapolis
Yep.
that are just done one right after the other. I do mine under general because that's kind of how we do it for that segment. And you can do it, believe it or not, under local.
Yeah.
So this is, it's not very invasive. And the tube here, the big one is 26 millimeters, but keep in mind, it's all soft tissue dilation.
Yeah.
This is
And it's
remarkably,
getting
very little pain after procedure. Immediately direct post-op, I've got some people that use Exparel and some of the longer acting. It's almost, we're reaching to a point, it's almost painless surgery.
And I was up in Kansas City a couple weeks ago working on the next generation of product, and this 26 millimeter dilator is going to get a lot smaller. We're still going to be able to drive the product through. Funny story for you guys. If you watch my social, there's a guy that came in my office, and I scheduled him for a Minuteman, and he canceled. And I was like, ladies, he was so excited. Why did he cancel? And they said, because somebody told him you were going to use anesthesia. And I said, well, yeah, I get it. So I called him. I was like, what's the hang up? He goes, I don't want anything but local. And so we got all the way to the 26 millimeter dilator. He goes, okay, I think I need a little something now. And we gave him 200 of propofol, finished the case. And every day, about a week after, he kept apologizing. He kept texting me. I don't know why I gave him my number, of course, because I wanted to get him on the table and help him.
Because you're a nice
But-
guy.
I did, but he kept texting me going, I'm so sorry I had to take that. I'm so sorry. And I'm like, dude, you're like a Superman in our
Yeah,
world.
no
So,
kidding.
but I do think there's a very realistic chance that most of our patients would have a good ability to get through the 20 millimeter dilator without having to have anything but local anesthesia.
Local anesthesia. You know I'm up the track.
Yep.
I think.
So there's a lot of new tools coming. This is a very innovative group. Again, I mentioned their leadership, their CEO, and their the people that are the engineers are working hard to make a product that's going to be better for us.